Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County, with another of our Facebook Lives. It's March the 2nd, Dr. Seuss Day, and we're going to do another of our Facebook Lives. We've already gotten some questions on Facebook questions at douglaspublichealthnetwork.org. But if you'd like to put in a question, if you do that at Facebook questions at douglaspublichealthnetwork.org, you'll be first in line. But if you didn't do that, put them in the chat section and we'll get to them today. So as always, this is a chance for you to ask questions and for us to answer them. We always do the best we can do, and so we'll get there today. So as we always do, we start at the top and then move down. So in the world, we had 114 million cases, 2.5 million deaths. The last few weeks I've been saying, look, the number of cases in the world is really coming down. It's come down, but now it's kind of plateaued. Deaths, however, are still continuing to decrease, but I'm a little worried about the plateau in worldwide cases and in U.S. cases. Still busy in the U.S. and France, and then little places in Europe, like Estonia. I don't think much about Estonia, but one of the countries, Latvia, Lithuania, and Estonia, there's a lot of disease. Czech Republic has had a tremendous amount of disease for about the last 4 weeks, and then Israel, Jordan, West Bank have continued to have lots of disease, despite the fact that they have very high immunization rates in Israel. And this is something to think about. So when we do immunizations do several things. One of the things they do is they help prevent severe disease, hospitalizations, and illnesses. And that's typically when we vaccinate seniors. So very clearly it does that. The second thing that you'd hope that vaccinations would do is to make the people who would otherwise spread it become immune so that they wouldn't spread it. So who is spreading this disease the most? Well, workers at nursing homes, so we try to vaccinate them, and they spread it to people in nursing homes. But in the community, the people who are spreading it are mostly young, healthy, active people who have young, healthy, active lives, and they go around and do a lot of stuff. We have done almost no vaccines on young, healthy, active young people. So would not expect to see that vaccines make a big change on transmission until we get to them. And we're likely not to get to that group really until May or June. So we've still got a few months until we get there. In the U.S., we're at 29 million cases, 525,000 deaths. Cases which have been coming down now, plateaued at sort of a nasty 70,000 a day. And deaths are still averaging 2,000 deaths a day. So as much as it's so much better than it was a month ago, 2,000 deaths and 60, 70,000 cases a day is a lot of cases. In Oregon, we've plateaued at about 400 cases a day. But at Douglas County, we continue to be high. We've eaten 10, 20 some odd cases a day, 25 today. So we're high. And that's been worrisome because this is the first time we've been above the state average. We're still not above the national average, but we're above the state average. And this is the first time we've been in this high and uncomfortable range. The big news, which is nationwide news, is that we've been on the lookout for variants. So variants are mutant forms of this virus. And the mutant forms of this virus we worry about because they can be more contagious, they could be more deadly, and they could be less amenable to the vaccine. And so we've been very, very, very carefully looking for variants along because we've been a little worried that our experience in this last month has been a little different than those areas around us. And sadly, very sadly, today or last night, we heard from the CDC that one of our cases from January tested positive for this variant. The variant it tested for was the P1 variant. So the P1 variant is it's a group of 17 unique mutations, 3 of which are in the receptor binding domain, which is in the sort of the business part of the virus. And they're in the 501st amino acid, the 417th, and the 484th. And what happens is, if you remember back in your genetics from high school, is that there's RNA or DNA that codes for the virus. 3 of those codons together are code then for an amino acid. If one of these changes, it changes the amino acid. So at the 417 level, it switched from lysine to threonine. In the 484 level, it switched from glutamic acid to lysine. And that ever so subtly changes the shape of this receptor binding protein And we think it makes it stick much more avidly to the receptor. So I think the way these work, the receptors are floating around, the receptors are on the cell surface, and these viruses are floating around. And imagine a weak magnet that may pop off, but then imagine where you'd get a very close fit and it would really get stuck and it would become more contagious. And that's what we've seen with this, is that this new P1 variant is about twice as contagious as the original. Well, the original is pretty contagious, so twice as contagious is very, very worrisome. The other thing that we see is that most people who've had a previous infection remain immune to it. So we think that less than 10% of the people who've had a previous infection will get it again in the next year. However, what they saw was that about 25 to 60% of those who thought to be previously immune got the disease again. That is bad, because that means that you've been through this once and think, oh, gone through it once, and now you can get it again. The other thing it means is that the antibodies that your body made to that first one are similar to the antibodies in the vaccine, and so the antibodies that you make from the vaccine may also not work as well. Now, this first variant was actually diagnosed this morning was diagnosed first in Japan from people who were traveling from Brazil. There's a place in Amazon called Manaus, and they found it. And since then, it's been mostly in Brazil. There are only 10 previous ones in the U.S., none on the West Coast until this one today. And this one that we got, it was a person who was a business person who traveled in South America and traveled back from South America, was sick when they got back. They were tested. They were found to have this. Our case investigators interview every case, and they interviewed this case. And one of the questions they ask is, have you been traveling? And they found out that this person had been traveling, and then sent this to the state lab and then to the CDC for genomic sequencing. Now, we did this back in January, and we just got the result last night, so a whole month delay. And this is a huge problem in the U.S., because as we get a month delayed, we're 5 generations of the virus out. So although this virus does have an incubation period between 3 and 14 days, it's really around 5 or 6 days. So if somebody had it 30 days ago or 34 days ago, this is now in our 5th, 6th, or 7th generation. And when you think of something that spreads that way, going back 5, 6, 7 generations is so complicated. Going forward 5, 6, 7 generations is really complicated. Think about it. If I have 15 contacts and each of my 15 contacts has 15 contacts, by the time to get to the second level, you're 225. By the time you get to 5 levels out, you're almost the whole population of the county. And that's why when you play these games of 7 degrees of separation with Kevin Bacon, you can almost always connect people. And in Douglas County, when I played that game, you can almost always connect people in 3 or 4 things. So at 5 generations, this could be widespread. Now, we don't think so. This person was very quickly quarantined. We think the only spread was within the family. And so we do not think this is spread wider, but we won't know until we do more tests. And one of the big concerns in this country is the slowness of doing genomic testing. And there's a big, long, complicated explanation if somebody wants to hear it. But the U.S. is terrible at this. We are only sequencing about 1 in 300 samples. It's not even that, and it takes a month to get them back, where other countries, for example, in Europe, are doing 100%. Not 1 in 300, doing 300 out of 300 and getting the results back in a week. So we're way behind in this country on doing that, typically because the CDC would do that, and the CDC is so far behind. So now people are coming up with other solutions to go ahead and get the genomic testing done in a quicker way. Let me get to questions, and then if we have time, there's a bunch of interesting things to get back to. So someone says, I'm 76 years old and have COPD, not dependent on oxygen. I had my first COVID vaccination. I'm due for my second in a couple of weeks. My question is, how long after the shots should I wait to go to do things such as get a haircut, go to the dentist, the eye doctor, colonoscopy? Well, all those things sound good to do. So at 76, you should have a colonoscopy every 5 or 10 years. At some point, we're all going to need a haircut. Going to the dentist is a good thing. So it turns out that if you had the Mrna or the Pfizer, which presumably you did, the Mrna and the Pfizer get their maximum efficiency 14 days after the second dose. So after you get your second dose, 14 days after, you're going to have as much protection as ever. Still doesn't mean that you should go and do something silly, but obviously none of those things you talk about are silly. I would still wear a mask. I would still socially distance when you can. But I think if you're looking for the safe time, 14 days after your second dose is likely the safest time. So Mandy says, how many of these new cases are in the nursing homes? Not very many. So the nursing home have really quieted down. Most of these outbreaks we're seeing now are workplaces and kids, and so it's a worry. Zay says, when will the J&J vaccine be here? It arrived this afternoon. Yay! So I was at the clinic today when they arrived with these big boxes containing the J&J vaccine. We were thrilled to have the J&J vaccine. So we've got the J&J vaccine here. It's wonderful. It's just great. We are going to use the J&J for complicated populations. So we think it's a great vaccine, but there's some people who have a really hard time coming back with the second dose. So for example, when we get to seasonal workers or homeless populations or people who just can't come back, that would be the ideal vaccine, so we'll be using it. The question is the J&J or the Mrna better? And the answer is I really don't know. So I can always come up with a baseball analogy. So the question is, was Babe Ruth or Willie Mays better? They were both fabulous, fabulous players. Were they better players? And the answer is I don't really know. Right at the time that Babe Ruth was playing, people had other jobs. They weren't professional athletes. We thought they only threw about 80 miles an hour. And so at the time, Babe Ruth was certainly great. Now, if you put Babe Ruth into the 60s, 70s, or the 2000s, would he have been as good? I don't know. But he was certainly great back then, and probably if he was playing now, he would be great. And similarly, Willie Mays played against much faster balls, many more curveballs, many more sliders, and yet they hit in the same kind of range. So who was better? The answer is I can't tell because they never played at the same time. And so for those of us who are sports fans, you can always sort of guess is Joe Montana better than Tom Brady, or was it Y.A. Tittle? And so you can just talk and you'll never know the answer. I think if I had to guess, Babe Ruth was great at that time, and if he was playing in the 70s, he would be great also, and that Willie Mays was great. And if he was allowed to play back in the 20s, he would have been great too, but you can't really compare them. So the Pfizer and the Mrna vaccine were tested in October, mostly in October and November of 2020, when there were very few variants, mostly in the United States where there were very few variants. Whereas the J&J was tested in UK, South Africa, Brazil, and the US, places where there were variants at a time when there were variants. And so I think it was a different time. And just like people will argue, was Babe Ruth or Willie Mays the better player? The answer is I don't know. And on these, I don't know either. I think they're both great vaccines. At some point, somebody will do a head-to-head on these two, but we're not going to get that data for years. So why are some areas of Douglas County currently vaccinating 70-year-olds and others like Reedsport still trying to vaccinate 80-year-olds? So Reedsport, we get a lot of questions about Reedsport. So the story in Reedsport is Reedsport was, on the coast. They were behind a little bit with the low numbers of vaccines. That all got fixed. They had a little trouble getting their call center up. That got fixed. So they're going to get a lot of vaccine over the next few weeks, and I think they're going to catch right up. So that's the greatest news. So the greatest news is, until I looked at the numbers of vaccines we had per first dose vaccines we had before, and it was pitiful. It was 500, 700 a week. This week, we got 5,700 doses. So we got almost as much this week and last week as we had all the times before. And so now we're in sort of a steady stream of getting vaccine, and the clinics are going to get into a much steadier stream. Again, we're working with Lower Umpqua Hospital. They've taken the lead at the coast, and they're getting 500 or so vaccines a week. In town, we're working with providers, increasing number of pharmacies. We added Rite Aid today to Safeway, Albertsons, Costco, 3 by Mars, Gordon's Drug, and we're hoping this week I have good news about some other pharmacies, so it's great. So Veronica says, my 82-year-old mother got her second vaccine and had no reaction. Should she be concerned? Well, I don't think so. We think that if you've got a big, strong reaction, like I had after the second Moderna, that was my body working to make an immune response. And we say that although there's no super duper proof that how tired you feel after the second dose correlates with how much antibody you make. It's okay if you had no reaction. We still think even if people had zero reaction, they still almost all had great performance. So I wouldn't worry about that. I would just be grateful that she didn't have a lot of side effects. My mom, 91 years old, got her first vaccine last night. I talked to her a few hours later. She had no side effects, so I was pleased about that. So Ronnie says, I had COVID in December. What vaccine would you recommend, or should I wait? This is a very complicated question about if you've had it. The reason is that we think you get pretty good protection for 3 months. And then there's a question about once you've had it, should you get 1 dose or 2? And so there's been a lot of academic research about that. I think I would recommend what I've recommended before, is that you probably, if you had it in December, I would wait 90 days after your infection so that others who don't have any protection could get the vaccine first, and then after 90 days for you to get the vaccine. And I don't think it makes any difference which one you get. So Susan says, how many active cases are there in Douglas County? Well, this morning we had 196 in isolation and 682 contacts in quarantine. So that's a lot of contacts. And the reason there are a lot of contacts is there are a lot of cases in school, and kids in school have lots of contacts. So you may have heard about a case on the Roseburg High School football team. And unfortunately, the way the rules are written, if there's one player on the football team who is positive and potentially exposed to the others, the whole team is out. And so that's why Roseburg is out until March the 8th. But that added a lot of contacts. I think we had over 200 new contacts this morning. So Linda says, with the Brazilian variant found in the nursing home that had so many cases, we do not know. We sent those off for variant analysis. We do not have the results back yet. That clearly is the worry, right? The worry is that the disease will get into a place like a nursing home and spread very quickly. So we were wary of that, so we did send them off for genetic analysis. We send off for genetic analysis any case that's weird. For example, a super spreader kind of thing, high mortality kind of thing. Somebody got the disease after they had the vaccine. Somebody got the disease twice. So anyone that doesn't look typical, we're sending off for variant analysis. But the problem is you can't send it off in January, get it back in March. And so I spent a long time on the phone today talking with people about trying to get that down to a week or 2. So if you got it down to, say, 2 weeks, that would be about 3 incubation periods. We can sometimes go back 3 incubation periods. But to go back 5, 6, 7 incubation periods like we had to do with this one is impossible. Yeah, so Casey says, I'm worried about homeless people in this new variant. Does the county have a plan to help get these people vaccinated? So they're not yet eligible for vaccine, but they will be at some point. The point being that right now we're doing seniors. The homeless population who are living dispersed have not been a big source of infections in Douglas County or really anywhere in the state. For the most part, the dispersed homeless populations are living outside in tents and not doing big congregation indoors. So it's congregating indoors or living in a household where this spreads. There's very little spread outside. Now, do we worry about them spreading in like a congregate, like the shelters and whatever? Absolutely. And so as soon as they're eligible, we do have a plan for vaccinating the homeless and people in shelters. We think the J&J vaccine would work great. So Sarah says, how do I know if my condition qualifies as an underlying condition? Well, it's on the OHA website, and you can look and see. The list is a lot narrower than you would think. So early on, there was talk about making a very expansive list that would include basically everyone. The list now is really, really much narrower. So I would have you go on the OHA sequencing guidance, and it'll tell you about that. So how is the COVID P1 strain detected? Can it be found with the rapid swab? Lacey asks. So the disease itself can be found either with a rapid swab or a PCR test. The variant is only, these 3 amino acids out of the 4,000 amino acids. So it's very, very, very similar to the other one. So it still gets picked up by the tests. But to do this, you need to do a complete genomic analysis. So what you need to do is you need to sequence the RNA in this virus and compare its RNA against the RNA of the previous ones. That is a super complicated thing. I will tell you that back in the 90s, I was cut into this, and we were talking about sequencing the polio virus, which is a much less complicated virus. And it took like 3 years of all the work in the world to do one virus, and they finally got it. Now they can do these in a week, but it still takes a week or so. So what happens is when we have somebody's positive, we collect the virus, we send the virus to one of these specialty labs that can go ahead and do the genomic analysis. And they're looking for a couple of different ones. There's the UK variant, there's the New York variant, there's the South African variant, there's the Brazilian P1 variant, there's the Southern California variant, and all of these are different. The concern that we have is many of these are in different areas, and if they all get together and make all of the changes, is that going to make the virus even worse? And that's why we're worried. And so with mutations only happen when the virus is spreading. So the virus is not spreading, it's not mutating. So if it's not replicating, it's not mutating. And that's why we're worried that in the US, we're still having 70,000 cases a day. We're still having a lot of transmission. And so many, 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 many more chances for this mutations to get even worse. So on the eligibility, so on our website today, we finally posted it, the OHA vaccine eligibility infographic. So take a look at that and see. So Lane says, are universities here in the state doing genome sequence testing? They can do it, I heard. So yes, they can. And that's what my phone call was about today, is that, for example, they picked up the Southern California variant in Lane County today at the U of O lab. And I don't care who does my genetic sequencing. It's such a mess. I just want somebody to do it. So we send all of ours to Oregon State Public Health Lab, and then they should send it off to whoever can do the genomic sequencing. The U.S. has a tremendous amount of genome sequencing capability, a phenomenal amount. We probably have as much as the rest of the world combined, and that we're doing such a terrible job in sequencing these is really quite embarrassing. So Virginia says, do you think our increased cases over the last few weeks are due to the new variant? It certainly is possible. It certainly is possible that they're due to the new variant, but it's certainly possible that it's not. And so again, we have sent off a bunch of specimens, and we should be finding out in the next week or so about whether they are the variants. So we're going to send a lot of specimens off for variants in the next few weeks. And when we do, if we see this again and again, then it probably did spread, because there are probably not a lot of other people who travel to South America. And so then it likely did spread. But if we don't see any for a while, probably did not. And I think this case was quarantined early and isolated early. So we don't see any obvious spread. But again, this disease, having so many asymptomatic people, could have spread. They might have been asymptomatic, given it to somebody else who then got symptomatic. The ability to tie those two cases together is really, really, really hard. Because we'll ask this next person, do you know anybody who's had it? No. Now they might say, yeah, I was around this guy at work, and they are the sibling of somebody else who had the disease. So sometimes you can pull it back that way. But when you have asymptomatic people in between, this is really, really hard to trace. Oh, so Samantha said, my son who's 14 had COVID, lost his sense of taste and smell for 7 weeks. Yikes. We do not know of anything you can do to make the sense of smell and taste come back sooner. That's a shame. I mean, smell and taste is a lot of what life is like, right? So if you can't smell and taste, food becomes much less appetizing. And for some people, they've even worse than a loss of taste and smell. They've had a bad smell or taste, a burnt smell or a musty smell or a metallic smell, and that's even worse. The good news is that most people have a loss of smell and taste, get it back. Although this week we saw a case that's been reported elsewhere where somebody had a loss of smell and taste with the first round of disease, got it back, and then lost smell and taste again, but didn't have COVID. So we're learning something new about this all the time. So the good news is, Samantha, that he's got a really good chance of regaining the smell and the taste. So Kat says, are Merck and J&J partnering up to increase production? Yeah, I mean, this is what we should do. I mean, if we were at a war and we needed to make airplanes, we wouldn't say, well, only this company can do it. Everybody else has to sit on the sidelines. So Merck, that makes a lot of vaccines, had their own vaccine that didn't work out. So they're kind of on the sidelines when it comes to the vaccine. And so what they figured out today was that Merck and J&J should work together so that they can up production. Absolutely. This is what we should have been doing all along, right? We should have been making billions of N95 masks. We should have been making billions of test kits. Someday when this is over and I write the book, there was a time where it was Q-tips that was the barrier to testing. Another time it was salt water. It was like, really? Salt water and Q-tips? Could it really be this complicated? And so certainly great that they're working together. That's exactly what the Defense Production Act was put together for. So the Defense Production Act says, we really need this. We're going to work with companies to get them done. We're going to, for example, help you build this plant so that you can do it. You may need like special roads or whatever, or special electricity to make this work. We're going to work with you to get that done. If you need raw materials, we're going to divert raw materials from some other so we can get it to you. So imagine if it was a war and you needed to make planes. Well, maybe instead of making soda cans, you divert the aluminum to the airplanes. Maybe instead of diverting, back in World War II, it was rubber. So then instead of rubber going to street tires, it went to Jeep tires. And that's exactly what this is about, is to increase production. Because the earlier we can get this disease down, the less the variants are going to be an issue. If this disease is still roaring in August and September, it is very likely that the variants will take over, which is going to make it so much harder to go ahead and get to herd immunity. So for those who can do math in their heads, the way you figure out what percent of the population you need to get to herd immunity, start with the number 1, and then you subtract 1 over the contagiousness of the virus. So if you had a disease like measles, which has a contagious factor of 15, one of the most contagious things we know, to get to herd immunity is 1 over 15, and that's why you hear to get to herd immunity to prevent measles from spreading, we have to have 95% of the people immune to measles. So that's 1 minus 1 over 15 is about 95%. In this one, originally when it came out, the contagious factor was 3. Now with the D614G, maybe 3.8 or 3.9. So to get to herd immunity, it's 1 over 1 minus, let's say, 4. So 1 minus a quarter is 75%. To get to herd immunity, that's doable. However, if it goes now up to 8, it's 1 minus 1 over 8, which means that 92% of the population has to be, I think this number, about 90% of the population has to be immune to make this stop spreading. That's going to be really hard to get to because we still don't have a vaccine for kids, who make up about 20% of the population. So Bruce says, my doc refuses to give vaccines. Why do some docs think that way? Well, docs are people, and they think different ways about different things, and everybody's entitled to their opinion, but some people think that this disease is going to go away without the vaccine. And all diseases will either go away or all the people will die. I mean, one or the other. but it could be really, really, really grim if we let this spread through, and especially if we go through and get it once and then get it again. So there's this city in Brazil called Manaus in the Amazon region. They had a terrible, horrible time with COVID back last year. They think that about 80% of the people had antibodies to it at the point, so that at 80% they said, well, we're pretty much protected. Now the P1 variant has come through, all those people are sick again. And so could you imagine going through this, having a terrible time with it, and then next fall having a terrible time again? And that's why it's so important to get this disease down now while we have vaccines. So Bruce says, would I speak to the differences between the vaccines? Yeah, so vaccines are, hold on a second. So there are 3 approved vaccines, the Moderna and the Pfizer vaccines, which are the vaccines that were approved originally, are messenger RNA vaccines. So they contain a little snippet of messenger RNA, and they're covered by a little fat globule. They get injected. What happens is those little fat balls get absorbed by the cell. The cell then, the mRNA tells the cell to make spike protein. The cell makes spike protein. The spike protein goes to the outside of the cell, and then the immune process starts. mRNA technology is relatively new, but in this case, incredibly effective. No big long-term side effects, no antibiotics in this, no animal products in this. So those are those vaccines. They are great vaccines. The several differences. The mRNA vaccines require really cold storage. Those little fat balls break down at regular temperatures, so they're a little hard to give, and you need to give them twice. The new vaccine is the J&J vaccine made by Janssen Pharmaceuticals. It's called a viral vector vaccine. So they take an adenovirus, a human adenovirus that cannot replicate. So it can infect you, so it can get into your cells, but it can't make new ones of itself. They put the genetic material from the coronavirus into it, and so then it gets into your cell, your body produces the protein, and again, your body then makes an immune response against it. They're both relatively new kinds of viral vaccines. So mRNA vaccines had been tried for a couple of other diseases like rabies and flu, and they were effective, but there was not an economic argument to make them. The adenoviral vaccines were tried with Ebola. They seemed to work, and so they were used in small numbers for other vaccines, but then got adapted to use for this. I think they're all great. The reported efficacy for preventing moderate disease from the Moderna and the Pfizer was higher than the J&J, but all of them are incredibly good at preventing hospitalizations and death. So are bars and restaurants dangerous to be in now? I'd like a definitive answer. Well, unfortunately, I cannot give you a definitive answer. So it is not the bar or the restaurant which is the issue. So it's clearly not, if you were in a bar all by yourself, seated 20 feet away from somebody else, a bar would not be very dangerous. If you were in somebody's house with 5 guys sitting around a card table playing poker, and you didn't have masks on and you were laughing and chortling and whatever, that would be dangerous. Similarly, if you move that same party to a bar, that would be dangerous. Similarly, though, if you move the sitting by yourself 20 feet away to your house, that would be okay. So what I'm saying is it has nothing to do with the venue itself. It has to do mostly with the behavior. And what are the behaviors? The behaviors are being close to somebody without a mask, whether you're at your house, whether you're at your bar, whether you're at a restaurant. It's mixing family groups. So again, if I have a dinner at my house with 5 different families in there, that's risky. If I had that same dinner at a restaurant or a bar, that's risky too. Now, restaurants and bars, they're there to get people to gather and take their masks down and do it. So it's not particularly the place, but it's what happens in the place which is dangerous. And since restaurants and bars tend to have people gathered together for meals and drinks, that's what they're about, there are those behaviors that are there. So the question is, should we close restaurants and bars? Well, really what we should do, really what we should do is if people avoided the high-risk behaviors. So if they avoided the high-risk behaviors, we wouldn't have to do this. Because if they avoided the high-risk behaviors, we would be in the low range and you wouldn't have to worry about this. So, but government can only do a few things, right? Government cannot say you can't gather in your house, right? Government can't say you can't have friends over for a poker party. They can close down restaurants and bars, and I think that's what's happened. But again, I think people are totally tied to the place, and it has nothing to do with the place. It has to do with the activity. So people want to say, what about grocery stores? There are maybe 300 people in the grocery store. Well, the activity that I'm doing in the grocery store, and I go to the grocery store several times a week, I'm wearing a mask. Don't ever take it off in the grocery store. I am totally distanced from people. I am never within 6 feet of people. And if I am close to somebody like the checker, there's plexiglass in between. They're wearing a mask, I'm wearing a mask, and it's 4 minutes maybe at the checker. So it's not a very long time versus being in a restaurant or a bar where you could be there for a long time. So again, what I want people to say, it's not the place, it is the activity. So if we all did this, we would have a low rate of disease and people could go to restaurants or bars. But I think we have a high level, and that's why we have the restrictions. So where can we get the J&J vaccine? So the J&J vaccine is going to be, only a little bit came, but some came. So it went to the Bi-Mart stores. So the Bi-Mart stores have J&J. And then we are also going to work with one of the ambulance companies to give J&J to some homebound populations. So there are some homebound people who really can't leave their houses, and how to get the vaccine, it's hard. So Cuddy says if you get a really bad reaction from the first vaccine, should you get the second one? So it depends on what the really bad reaction was. So if the really bad reaction was a near anaphylactic reaction, you should definitely talk with your doctor or an allergist before you get the second. If the really bad reaction was like, that hurt like crazy, or I was really tired, or I had fever, then yes, you can get the second one. So you really have to define what the really bad reaction was. So the really bad reaction was hives, difficulty breathing, swelling, anything that looked like an anaphylactic reaction, you really should see an allergist before you get the second one. So will the Drain Aviva facility have immunizations? Tanya says, and I don't know the answer, but you can call them tomorrow and see. Do we have a choice of which vaccine to get? Well, most places are not going to, I don't think there's any place that has all three vaccines. So, in fact, I think that's correct. I don't think there's any place that has all three vaccines. So people get whatever vaccine they have. Most of our pharmacies are getting Mrna, some are getting Pfizer, and as I said, the Bi-Mart's got J&J directly from the state. So I imagine you could ask the pharmacy which one they're given, and then if they say they have one you don't want. But my sense is I would totally agree with Dr. Fauci on this one. Get whichever one you can get. I mean, they're all really good. I would just get whichever one you could get. And I think the only way you get the choice is you have to call them, find out which vaccine they have, and if they don't have the one you want, then don't go there. So Bruce says, would I stay with a primary care doctor that refuses to offer COVID vaccine? Again, doctors have free choice, they have free speech, they can say what they want, and I may disagree with them. I mean, personally, I'm such in favor of vaccinations and COVID vaccine that I would be shocked if my doctor didn't give COVID vaccine, and I would say, what's up with that? Now, there are some doctors who are not giving COVID vaccine for a really valid reason. To give the COVID vaccine, you have to be signed up. It's a complicated sign-up process. I've been working a number of people through this, and it isn't easy. So if you had not previously given vaccines before, to get signed up from the beginning to be able to give the COVID vaccine is a very complicated process. So I've spoke with a couple of the internal medicine doctors, mostly take care of older people, who don't give any vaccines. They don't give flu vaccine, they don't give Shingrix, they don't give anything. They send every one of their patients to the pharmacy. that is not a totally unreasonable choice, because giving vaccines is very complicated. So at Aviva, where we do a lot of vaccines, we have this refrigerator, and the person who does the vaccines talks to people and they say, look, you have to be careful with that refrigerator. It's got like $100,000 worth of vaccine in it. And one refrigerator has $100,000 worth of vaccine. So it really is hard to manage to be sure you get it right. They have this phenomenally complicated system of backup power, because power goes out and these things need to be kept at extremely, exquisitely close temperatures. And so they've got generators and backups, and people get phoned and beeped and whatever if it goes out of range, because these vaccines are so hard. So for doctors who don't generally do vaccines, for them to now start doing COVID vaccine would be complicated. So I think I would talk with my doctor and say, well, what's up about this? And they say, well, we are just not set up to do vaccines. We generally work with the pharmacies for them to give Shingrix and Pneumovax and pneumococcal vaccine and whatever else, and we're happy with that arrangement. That would be fine. If they said, I think there's no data the vaccine works, I'd say, really, where'd you hear that? So that's where I would go. Okay, well, a couple of things. People over the months have asked about blood types, and a new study came out about blood types, and blood types really do make a bit of a difference. O negative blood is good. You seem to have a lower rate of severe disease. B positive, my blood type, is bad. You seem to have a slightly worse rate. So what's the difference on all of these? So somebody asked me this question: what's the additional risk for certain things, like having bad blood type? It's about 10%. So it's about 10% worse if you have B positive than having O negative. 10%. Well, 10% is important in the big scheme of things, but for an individual, I don't know about 10%. What about an underlying condition? Well, once you adjust for age, most underlying conditions don't really have that big a factor. So a BMI more than 50, yes, really does. But if you have a BMI of over 50, so that would be if I weighed 500 pounds, that would be bad for me in so many ways. But other things like cancer probably only change your risk by a few percent. So it turns out that the underlying condition is not as predictive, as far and away the two most predictive factors are age. So at any age, go up 7 years, it doubles or triples your risk. Go up another 7 years, doubles or triples your risk. So if you look at the risk of death from COVID, comparing somebody who's 15 years old to somebody who's 85 years old, it goes up by 8,000 times. Not 8,000%, 8,000 times. So the risk tremendously increases with age, and every 5 or 10 years, you're doubling or tripling your risk. So that is the concern. Age is far and away the best predictor for death. And in fact, when you look at the deaths in Douglas County, all the deaths have been people over 60. When you look in the deaths of the state, most of the deaths have been people 50 and above. There are a lot of people 40 and 50 who have cancer and whatever. You don't see any deaths there. There are people with heart disease in their 40s. You don't see very many deaths there. Far and away, the strongest predictor is age. The second strongest predictor, oddly enough, is race and ethnicity. So Hispanics, Pacific Islanders, blacks, they have about twice the rate. So 100% increase. Remember I said blood type about 10%? This is 10 times as strong. So those are really the strongest predictors. The underlying conditions, once you adjust for age, make a little difference, but not all that much. So again, far and away, the most important thing is age. So some states, for example, Connecticut said, rather than all these pages and pages of figuring out how to do it, we're going to go straight by age. Because a 50-year-old is 2 or 3 times more likely to die than a 40-year-old, who's 2 or 3 times more likely to die than a 30-year-old. And all those other things are just noise. So whether you're in essential work or this or that, Oregon has really made an incredibly complicated system. I looked at the thing the other day and said, oh, geez, I could never figure this one out. They made an incredibly complicated system, whereas other countries really have gone strictly by age, because if you're looking to prevent deaths, which would be clearly one of the things you want to do with a vaccine program, the easiest and best way to do that is to go by age. So if you take a 63-year-old with no underlying conditions, they are far more likely to die than a 24-year-old with even 2 underlying conditions. I mean, 20 times more likely to die at 63 with no underlying conditions than a 20-year-old with 2 underlying conditions. So again, my sense would be I would go by age. Going back to the question with Bruce is, would I stay with a primary care doctor who refused to offer vaccines? I asked him what their issue was. If their issue was, we just can't do it operationally in our clinic, we've always relied on the pharmacies, then that's a good story. If the story is, I don't believe that vaccine works, or I think COVID is not real, I'd have to scratch my head. Okay, a couple of other things here. Here. So if you get any more, so one of the questions that came up last week is about the American Medical Association supporting or not supporting the use of hydroxychloroquine. So that I'm a delegate at the AMA, so I know what goes on there. They have not had any official statement about hydroxychloroquine. And the question was, well, hydroxychloroquine, what about the WHO? Well, WHO doesn't believe it, doesn't think it's worthwhile either. So you get different opinions about hydroxychloroquine. One of the opinions I hear is, well, that it doesn't work when you're really sick in the hospital, but maybe it works to prevent disease early on. 2 good studies that looked at that. So people right at diagnosis, they gave some hydroxychloroquine, some something else. It didn't seem to make a difference. The other one that's very controversial this week is Ivermectin. Again, there's some small studies suggest that it might work, but with 60,000 cases a day in the U.S., we should be able to really adequately test this within a month. And it's been going on for a year. And so without me seeing it would suggest it probably doesn't. The other thing that I talked about 2 weeks ago, that just I saw in the journals today, was that some people, after they get the vaccine, will get swollen glands. And so anytime your body gets provoked, I get a cut on my foot, I get a bruise on my ankle, I'm a little baby and walks into a table, you get little glands that grow up in the area that's responsible for drainage of that area. So in your legs, the place that's responsible for the drainage is your groin. And so if I get a big infection in my foot, I may get a swollen gland in my groin. Interestingly, if you check with babies who are just starting to walk, they're always bumping into things and whatever, they almost always have little glands in their groin. And so if I've taken care of any of your kids, you can be, as I feel there, say, oh, feel this little lump here. It feels like a little BB. So it's normal. So if you feel that's the time when you change the diaper, don't get worried. It's a normal thing during childhood. And so there in your arm, the glands that are responsible for your arm are in your armpit. And your armpit's also responsible for your breasts. And so women, when they do breast self-exams, are also taught to feel to see if they have any adenopathy in their arm. And there have been a number of women who've had that following a COVID vaccine. It's not cancer. What it is, it's a reaction to the vaccine. And it was reported in the studies that some people would have adenopathy afterwards. So there was a study today suggesting that people will have this and they worry that they have cancer. And it really turns out that it's just a reaction to the vaccine. So if you note lumps in your axilla after you've had the COVID vaccine and you're worried about that, you should still see your doctor, but you should say, oh, and I want to remind you, I did have my COVID vaccine 2 weeks ago, 3 weeks ago, 4 weeks ago, because that may steer you away from a bigger diagnosis. The other thing we looked at is we looked to see how countries have done with this in terms of number of deaths per million people since the beginning of the pandemic. Now, that is not a perfect measure because there's differences between countries and whatever else. Reporting may not be great, but it's one of the ways to look at it. The other way we looked at it is people said, well, urban areas are going to have a much harder time with this, or populated areas are going to have a much harder time with this than unpopulated areas. So we did a scatter graph where we looked at population density, that is the number of people per square miles, and did it against how they did with COVID. And it looks like there's no pattern at all. So some of the least population dense states like South Dakota have had the highest death rate, whereas other really dense states have had a high death rate like New Jersey. But then other really dense states like Rhode Island has had a relatively low death rate, and then relatively populated states so it's all over the place. So when people say, well, yeah, it's easy to get low rates of disease in Douglas County because you're rural, that does not seem to play out. In fact, while Douglas County is rural, much of it is federal land where there's nobody living. So if you look at the number of people in Douglas County living in the areas where you can live, since you can't live in the national forest really, our population density is not all that off. Other thing we looked at is to see how many deaths per million countries have had over time. So if you look at the countries that have done the best, I mean, places like Taiwan and New Zealand have had less than a few deaths per million, whereas places like South Dakota had 2,500 deaths per million. So there's a huge variation between states and areas. So when I pull the graph up here, so looking at the number of deaths per million since the beginning of time. And so when we look at the place that's done the best, it's Taiwan. They have 28 million people. They've only had they've only had 9 deaths. So 28 million people, they've only had 9 deaths. Now Taiwan has been incredibly strict about when people come into Taiwan that they need to quarantine. New Zealand, a country of 5 million, has had 26 deaths. Norway, a country of 5 million, has had 622 deaths. Finland, a country of 5 million, has had about 700 deaths. Then you get to a place like Oregon, with a population of 4 million, we've had 2,200 deaths. So 3 times worse than Norway and Finland, many times worse than Taiwan. But then when you get to a place like, Brazil, with a population of 213 million, so it's a big country, they've had 255,000 deaths. So while Oregon has had, if you look at deaths per million, Oregon's had 523, Brazil's had 1,100, almost 1,200. And then you look at Sweden, which has gotten played up as being great. So remember Norway and Finland, in deaths per million, they were about 134 and 175. Sweden at 1,321, so 5 times as many deaths. So when you put this all together, having the deaths is problematic. And when you look at the highest places, Massachusetts, South Dakota, New York, our state of Georgia, Italy, have all had over 1,500 deaths per 100,000. Really pretty shocking. And South Dakota with 2,134 deaths per million. That's a lot. So again, the world is done differently. In many places, you'll see in pandemics they affect countries slightly differently, but to see the difference in this be 1,000-fold is really very shocking. And when this is all over and people write the book on this, I think that the differences in countries and states is going to get played out. All right, let's see what else we have here. It's getting to be time here. All right, well, there are no more questions. We'll do this again. Just a couple of things. The variants are very worrisome. As I said, we've only had 1 case and spread only within the family. We do not think it's spread elsewhere. But what we do know is that the things that work for the good old COVID work for the new variant COVID. Wearing a mask, socially distancing, staying home when you're sick, all of those things work, and they work just as well for the variant as they did for the previous. So I would encourage people to do that. Well, thank you again. We'll do this again on Friday. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. Thank you.